what are the cardiac markers? Basically, you look at myocardial injury markers like tropi, and you also look at NT-proBNP to look at the degree of failure element. And both higher the marker levels, worse the prognosis. So they are indicator of the severity of the illness also. So coming back to this particular patient, he was in vasopressors with increasing doses, EF of 20% with S prime of less than 7.5 centimeters per second. His cardiac enzymes were raised. ECG has no specific signs. Urine output started falling. On POCUS, you had B lines on chest, thoracic chest ultrasound. The mixed venous saturation was 55%, central venous. Lactate was 8 and FiO2 now was 70%. So overall, the condition was going down. So we started dobutamine infusion in view of his low ejection fraction and stroke volume. And because of renal dysfunction, AKI, and falling urine output, he was put on CRRT. And we started advanced hemodynamic monitoring with flow track. So what did we targeted a cardiac output of more than 4.5 liters, of 4.5 liters per minute, MAP of 65, SVV of less than 13%, hemoglobin of more than 7, and SVO2 approximately 70%. Subsequently, the further worsening was halted, the patient stabilized, his hyperlactatemia improved, FiO2 requirement came down, saturation remained well, gradual decline in vasopressors happened, and tropi stabilized at 1.5. So on day 6, vasopressor requirement was substantially reduced. It was off vasopressin. Noradrenaline also came down. Repeat echo showed an EF of 50% with no RWMA, and patient was successfully extubated. Day 8, he was off vasopressors. Saturation was maintaining on room air. The kidney function was getting better. He was afebrile, his white counts are normalized, shifted to the ward, and we were asked to follow up with urology for his renal pyelonephritis. So basically, detection of cardiac dysfunction and upscale monitoring as an algorithm which has been made. So you start with assess initial response, start with basic monitoring, particularly looking at tissue perfusion, that is also CRT. Then if the patient is improving, rapid improvement with minimal organ dysfunction, then you continue with your basic monitoring. You may or may not add stroke volume and cardiac output monitoring. And frequently you re-evaluate the patient doing the echocardiography. If initially the patient has high doses of vasopressors with significant comorbidities or organ dysfunction, and obviously confirmed on echo, cardiac function is inadequate, then you look at the LV and you look at the RV dysfunction, and then you may consider pulmonary artery catheter or other minimally invasive techniques to monitor the systemic vascular resistance, stroke volume variation, etc., to look at how to manage these patients. So you check the CRT, tissue perfusion, or lactate, mixed venous saturation, or arteriovenous carbon dioxide gap, PO2 gap. Is cardiac output adequate? Yes, then re-evaluate the patient frequently. If the cardiac output is not adequate, then is the patient fluid responsive? If he is, then you give fluid. No, look at LVOT obstruction. If LVOT is obstructed, then obviously you need to come down on your vasopressors and inotropes, decrease inotropes, increase vasopressors, and give some fluids. If there is no LVOT obstruction and the patient has LV dysfunction, yes, then you start inotropes. If there is no LV dysfunction but there is RV dysfunction, then obviously you require inodilators, something which will improve the cardiac output, reduce the afterload of the right ventricle, and also readjust your ventilator settings so the airway pressures are not very high. So this is how one should manage. This is the algorithm for management. Begin with vasopressors, initial fluid assessment and fluid management, inotropes, rate control, and finally mechanical support. So etiology, obviously one has to diagnose fluid expansion, vasopressors, and you may have to add beta blockers or inotropes or calcium sensitizers. I'll come to that. So what is the stepwise approach for inotropes in these patients? Just begin with a low dose of dobutamine and slowly titrate it to increase it at 2 points. So begin with 2.5 mics per kilo per minute. You may have to add a vasopressor, vasoconstrictor in order to maintain the MAP. When the doses are higher, maybe 20 mics per kilo per minute, then you need to add another vasopressor like vasopressin. If the cardiac index is low, then think of an alternative inotropy like a phosphodiesterase inhibitor like milrinone. And you see titrate the blood pressure by adding more vasopressors or increasing the dose, because milrinone is also a vasodilator. Then still the stroke volume remains low, then you may require a calcium sensitizer like a levosimendan, because it bypasses the beta blockers, and sometimes the beta blockers, not only the sensitivity is reduced in these patients, but also the number of beta blockers density also may be reduced. But again, levosimendan can also produce vasodilatation, so you may have to titrate your vasopressor dose. Always remember, levosimendan is a long-acting drug. And whichever drug you use the lowest possible dose to achieve your goals, and you wean off as soon as possible.